Once again, thank you for taking time from your busy lives to join us. It is our distinct pleasure to welcome Dr. Stanley Herring. He is a board-certified physical medicine and rehab physician who has been in practice for over 40 years. I can't believe that, Stan. He's a clinical professor in the Department of Rehab Medicine, Orthopedics and Sports Medicine, and Neurological Surgery at the University of Washington. Dr. Herring holds a Zachary Lysted Sports Concussion Endowed Chair. He's also the co-founder of the Sports Institute at University of Washington Medicine, where he serves as the senior medical advisor, and he also serves as co-medical director at the University of Washington Medicine Sports Concussion Program. He is co-medical director of the UW Medical Orthopedic Health and Sports Medicine and one of the team physicians for the Seattle Mariners, and he formerly held the same position for many years with the Seahawks. Dr. Herring is a major contributor to the successful passage of the Zachary Lysted law in Washington State, and he has continued efforts to help pass similar youth concussion legislation in all 50 states and the District of Columbia. Welcome, Dr. Herring. Thank you for joining us.
Well, thank you, Melanie. Thank you for that kind introduction. Even the parts that were true were nice. And thank you, and Melissa and everybody else at Siebert. I am just such a fan of your organization and the work that you've done, and what a privilege to spend a little time with you this morning. Doing so, after talking with Melanie, I just wanted to show a few slides to kind of set the stage. You mentioned some of the things I do, just so the group knows that I am involved quite a bit in different types of concussion, including international concussion writing. I help the NCAA with their protocols, and I've done some work for the CDC as well, just so people know my background and things that may influence my thinking. I'm always happy to talk about brain injury, and given this audience, it couldn't be a better group, and this is a common problem. I think in terms of sports alone, there's upwards of 2 million sports-related concussions every year in school-age children, and that's just in the United States alone. The good news is that 80% are really better in about a month. So this is an injury that has a fairly positive prognosis. This is a bit of a good news, bad news situation, because if 80% are better, that means 20% are not. But this group and others like us have the opportunity to intervene. So in sports, the tragedies that are due to concussion are usually preventable. So it puts the onus upon us to be interested, available, and ready to help make the suspected diagnosis and treat that acute concussion correctly. Because if you don't, rarely catastrophic things can happen. And I am very honored to hold the Zachary Lysted Sports Concussion Chair at the University of Washington. Zach was a 13-year-old football player who was allowed to continue playing while concussed, and had a devastating brain injury. Thanks to the care at Harborview, he was saved, but the consequences to Zach, his family, and his community were so overwhelming. And the family is such an extraordinarily positive family that we worked hard to, with their help, to turn the tragedy of his injury into legislation. And Zach is 30 years old now, and just still my personal hero, and Mercedes and Victor. It's an extraordinary family who have had a profound effect on my professional life and have become personal friends. So any lecture I give that talks about brain injury, I always like to honor the Lysted family. And Oregon was just as progressive. Max's law and then subsequently Jenna's law have covered the same topics. Oregon should be proud of the legislative effort that the state has made to help keep kids safe. And there's a lot more concussions reported than there used to be. So people have often said to me, well, then there must be a concussion crisis. This may be really a bias in reporting. I'm not sure there's any more concussions than there ever have been. We're just better at reporting them, which is a great thing. So I welcome reporting, even over-reporting, even the suspicion. But I must ask you, since we're giving this concussion talk, what the most dangerous thing that we can do to young people that would affect their long-term physical health, psychological health, and neurologic health, as well as their academic performance, what is the thing that we must be the most concerned about that almost would guarantee that these young people will have these tragedies and challenges as they get older? Well, the single most important thing that we can prevent is actually physical inactivity. And I'm a brain injury doctor and a brain injury advocate, but I'm saying to you that we have to be very careful that we don't ignore the single biggest risk factor for chronic neurologic problems, academic performance, psychological problems, and that's being physically inactive. Physical activity is really a magic elixir. If you're physically active as a kid and a young and an adolescent, your strength is better, your motor skills are better, you build healthier bone, your mood is better, your heart's better. You're able to help prevent things like type 2 diabetes, which is rampant now in young people, asthma, hypertension, heart disease, sleep apnea, depression. If you're physically active as a young person, you're more likely to be active as an adult. And if you're active as an adult with physical activity, you can prevent a variety of issues like heart disease. Even 13 different types of cancer have been shown to be limited or affected by exercise. Diabetes, depression, anxiety, it's really sort of a magic pill. It doesn't, in of its own, prevent obesity, but it helps aid in the treatment along with some calorie restriction. And you know what? It basically lets you build a better brain when you're a kid. So kids who are physically active also show improved focus and they learn faster. And kids who play team sports have better self-esteem and social skills. And adults who are more physically active have, for example, a significantly decreased, reduced risk of depression. And as I've said, it prevents many types of cancers, diabetes, and chronic neurologic disease such as Alzheimer's. It's very helpful in the prevention. However, in our country, 80% of adults and 76% of kids don't get enough exercise. If exercise was a vaccination or a pill and we didn't give it to kids, they would take our licenses away. But yet here we have this incredibly important intervention, which is just not used. And there's a real problem with being physically inactive. So right now, children in the United States spend a little more than 7 hours of their waking days in sedentary pursuits. And so in the United States, only about 25% of kids meet government recommendations, which is an hour of moderate to vigorous exercise daily. Fewer than half of American children have adequate heart fitness. As a matter of fact, the average screen time now in the United States for children is a little over 7 hours a day. And that's not necessarily always smart screens either. At the same time, the prevalence of obesity has doubled in children and quadrupled in adolescents over the last 30 years, just devastating lifelong problems. So people say, well, that's fine. I don't want to have children be active, but inactivity doesn't mean they can't, just because you say they can't play football or lacrosse or soccer, they can still be physically active. And I think that's true too. We were chatting earlier this morning. You can tell that to children, but we did a little bit of research and we wondered, is there any evidence that if you ask a child or their family to change sport, that actually happens? So will they stay active? I mean, okay, no more football. Let's pick up the golf club. Well, it turns out that there's no evidence that telling a child to change a sport will actually let them change the sport. So yes, collision and contact sports have danger, but we have to be very careful and not to be too parental and dictate activity to children where sports may solve a lot of different problems. Maybe the football field is the only safe place for a young boy to exercise, or maybe being on a soccer team is really critically important to help a young girl get her self-esteem. So I think be very careful about just go do another sport. Just do something which isn't contact or collision. If you're inactive, it directly and indirectly raises the risk of chronic disease across your entire lifespan, as we said. Physical inactivity as a standalone risk factor, independent of obesity, diabetes, or other issues, looks to be about the fourth leading cause of death in the world. This is really the true crisis is this crisis. So I guess my point is that yes, we want to keep kids safe. No one more than the people on this Zoom. But at the same time, we have to be very careful to balance benefits of exercise versus the risk of being physically inactive. So we want to keep kids safe, absolutely. We want to keep kids active, absolutely. And we want to be careful about drawing conclusions about what we think is right without knowing. And hopefully we can spend some time with the rest of this Zoom trying to answer some of those questions. So I'm going to climb off my high horse and see if we can't move forward our conversation. Let me see if I can get out of this and I'll get back to you.
Folks, go ahead and put your questions in the chat or the Q&A.
Okay,
You're good? Okay.
good. Thank you.
Yeah. So Dr.
Thank you for letting me prattle on there a little bit.
Oh, thank you. I'm going to quote you at this point. I've quoted you many times. The mystery of a given patient is in their history.
Yes.
So can you speak to a patient's, when a child comes back to school after a concussion, talk to me about the history of depression and anxiety and how this could potentially affect their recovery.
Sure. Let me, I see one question from Pepper, a name I love.
Uh-huh.
Pepper, there's no evidence that wearing a helmet in soccer makes the sport safer, and I don't recommend it. It doesn't really prevent concussion or brain injury and may give a false sense of security. So the quick answer is play soccer, no helmet. And we can talk about that more if you want to. And Melanie, to go back to your.
Oh, sure, sure. The mystery of a given patient is their history. So talk
Sure.
about their depression and anxiety secondary to that concussion.
Sure. And, we, in our office, we tell our residents, if you've seen one concussion, you've seen one concussion. They're like snowflakes. They're all different. And as I said earlier, most concussions get better about a month, but we are increasingly understanding that it's very important to understand what the athlete brings to the injury. Their life experiences, their belief systems, their family belief systems. The strongest predictors of having long-standing symptoms are the burden of the concussion, how severe it is. But right behind that are personal and family, psychosocial and psychological issues. So the mystery is in the history. You need to know who you're treating. So if you have a young athlete and she or he are just not getting better, of course you're obligated to make sure you're not missing something on the brain injury side. You should get a better workup, but be careful about attributing these long-standing symptoms only to the concussion without understanding that there may be other drivers. If you have athletes with persisting symptoms, they have headache and they can't concentrate, they don't sleep well. The same thing is true for people with depression. The same thing is true for people with anxiety. The same thing is true for people with a migraine headache disorder. So we have to be careful to make sure that we pursue a thorough workup for a young athlete with persisting symptoms.
And we have Misty again in the chat box, and this is a great question, and thank you for posting that, Misty. Can you see that, Stan? So what kind of testing is recommended for young athletes after a concussion? Also, if neuropsychological testing is recommended, what exactly does that mean, and who can administer the testing? Great questions.
Great questions. The fact that you can talk to me, Melanie, and look at the chat box creates envy on my part. I'm lucky if I can get my slides off the screen. Great question. The majority of concussed athletes don't need any special testing. You can use the forms that we developed in Amsterdam, the sideline concussion assessment tool and the office assessment tool. Those are for healthcare providers. You monitor the athlete, you gradually reactivate them, and then they return to activity. If they have symptoms that persist, then there may be the need for diagnostic testing. Rarely, but sometimes brain imaging. There may be a need to address or treat their dizziness or their vision changes. Some people do neuropsychological testing at a baseline, and then after testing, after concussion, we're moving away from demanding or requiring baseline testing. If you have it, it's good for comparison. Neuropsychological testing allows you to test certain domains in a more detailed way than you can by physical examination. And so that may be helpful. If someone has persistent thinking or concentration problems, you can have a neuropsychologist test them to see if they really have processing issues or memory or concentration issues. Sometimes that's helpful because the neuropsychological testing may be normal or within normal range, but the athlete's symptoms, which once again would drive you to think maybe there's something else causing these symptoms. I think the short answer to your question is if an athlete falls outside the expected recovery curve, which is a month, just so we're clear, and you wonder why, that is the time to seek care in a center with expertise around brain injury, because they will have Melanie, especially of speech pathology, and they will have occupational therapy and physical therapy and neuropsychology, and hopefully a brain injury doctor who can sort out with your individual athlete why they are not recovering in the expected fashion.
Excellent. So many of our students, I come from the school slant, and we have concussion management teams in our high schools. We're working really hard to get these students back to return to learn quickly.
Yes.
We have many students that complain of persistent and debilitating headaches, vision issues after a concussion. These symptoms obviously increase the anxiety, depression, and school attendance, which leads to even more problems, just a multitude of problems. Could you, Stan, give us some advice on how to handle this scenario?
Sure. And this is an increasingly common problem. So once I'm going to say this every time I give an answer, you have to respect the brain injury. I don't want anyone on this Zoom to think that we're saying that these young athletes don't have a problem. They do. And the number one responsibility you have is to make sure you haven't missed something. Did you miss a small contusion or subdural hematoma? So the expertise of that is critical. Did you make a mistake? Did they rest too much? Right? Or did they not rest at all? Right? So you have to, your responsibility is to first do that. And then, Melanie, when you see these young athletes who are struggling so much, they have an incapacitating headache. Maybe they developed a post-traumatic migraine headache disorder. See, once again, it may not be the concussion. Or they have a persisting headache and they're nauseated and the room spins around. Maybe they had a peripheral vestibular nerve injury. Or they can't focus and their vision is off. Maybe you need to evaluate their ocular motor system. So what I'm saying is, I hear you loudly. The tragedy, Melanie, is when they get further and further behind in school.
Mhm.
It is impossible to catch up, and it creates its own tsunami.
Right.
And so, thank goodness for your concussion team at your school, and it's so critically important that this idea of going in a dark room until you feel better and then doing something. We're saying now, 24, 48 hours of relative rest, and then let's get going. I mean, obviously not to the degree that makes you worse, but let's get kids moving cognitively and physically. So early intervention, early activation within reason. You do need that concussion team. They're lucky if they have you as a speech pathologist because basically you're a learning specialist in that regard. But put your team together, move kids quickly back into at least some academic activity. And if they get stuck and the disability just doesn't change, then the sooner you seek multidisciplinary care, the better. Don't wait 6 months. Don't wait. I mean, if you're worried about it, make a referral quickly. I mean, and people say there's resources in Oregon. It's not always easy, but there's young people have other illnesses where it's not easy to find resources either, but there are resources. And getting that validation that you've treated the brain injury correctly, and you can begin to move that young athlete through some areas where it may be uncomfortable for them. Okay, I know that you don't feel well today, but we're still going to walk for 30 minutes. We're going to monitor that for you, and we're going to do a little bit of reading. We're not going to take your screen away from you for 24 hours a day, 7 days a week. That's the trend now.
I think we see a lot of kids coming back and they just are scared. They get out of bed. It's like, I know I'm going to have a headache, therefore I will not go to school.
Right.
Very
Yeah.
serious. So can you say,
I had a delightful young fellow tell me, he said, well, I know I'm concussed. He says, I'm thinking, but I'm trying not to think any deep thoughts.
Mhm,
And
mhm,
I said, how do you, he was worried that if he had deep thoughts, he would damage his brain. And this is once again the mysteries in the history. You have to understand the worries and the belief system of the person you're treating. And then you can help educate them and their families about what to worry about and what may be a natural recovery from this injury.
mhm. I've heard you speak before about the Hawthorne effect or the fear avoidance model. Can you speak
Sure.
to that a little bit, please?
Yeah, a bit of my work is in the pain world, and I didn't realize that there might be such overlap. So patients with persisting symptoms after an injury, pain patients, patients with pain, or patients with persisting symptoms after a concussion have some similarities. One of which is the Hawthorne effect is if you pay attention to people, they get better.
Mhm,
So engaging them and not isolate them. And basically, I think healthcare providers need to be purveyors of hope.
mhm,
So sometimes, I mean, people get all into what should we do, oculomotor therapy or vestibular therapy or cervical spine therapy. I say, if you just pay attention to this young athlete and give her hope, there's a chance that she'll get better. So your first one of your first duties, and then we are using some other models. For example, this young athlete you propose, I know I'm going to have a headache. I'm catastrophizing. I'm not going to go to school.
mhm,
So we do a little bit of kind of exposure therapy and say, you know what, we're going to talk for 20 minutes. You know, we're going to do some affirmation work. We're going to show you that you're not damaging your head. You're not going to, and we basically desensitize them to some belief systems. Once again, after we're sure there's no underlying pathology, but we're using similar models, activation models, collaborative care models to help children and their families who are crippled, disabled by symptoms which we think are treatable.
mhm, mhm. Excellent. Um, Elaine, I promised to get your question. We're kind of on this thread right now. So, Missy, what guidelines do you recommend for determining when you tell a student athlete that they can no longer play contact sports? So,
Yeah.
who's on the team? Who determines the final decision? Great question.
Misty, it is a great question. And it's such a great question that we just recently released the concussion sport guidelines from Amsterdam. It was published in the British Journal of Sports Medicine. This year, I mean, that's a 4-year process. This year, we added a new section upon retirement. And, you know, and I think it's worth reading, and I will summarize it for you. I don't use the word retirement as much as I use the word redirect for the
Mhm,
reasons that I tried to emphasize to you in my introductory slides. Telling a young athlete, okay, you can't play football, you can't play lacrosse. That needs to be tied to how am I going to redirect you to stay physically active. So that's important. It turns out that there's really not much research. I mean, this idea of 3 concussions and you're out, that actually is not true. So there are times when, as a healthcare provider, I'm more concerned. A structural lesion in the brain, you know, a big cyst or a subdural bleed that leaves scarring, someone with persisting neurologic deficits on examination, someone with persisting significant neuropsychological changes on testing, someone who has increasingly long concussion symptoms after more and more trivial trauma. So there are things that worry me that my risk tolerance makes me think the athlete should retire. However, I have to balance that with the wishes of the athlete and their family.
mhm,
And this opens up the concept of shared decision making. So it's what is my tolerance for risk and what is the family's tolerance for risk. So I think that you have to respect the autonomy of the athlete, and if they're a minor, of the athlete and their family. But there are things that make me worried, the things I just listed. And I will say that families, in my opinion, my professional opinion, I don't think it's good for your son or daughter to continue to play collision or contact sports. But at the same time, I will listen to their own feelings and then try to understand their point of view. Some families, listen, I've had families that say the only safe place for my daughter is the schoolyard.
mhm.
I mean, that's the only place where she's physically sick, and you have to weigh that. I would encourage you though. It's the concussion of sport Amsterdam guidelines are freely downloadable, and just if you take a peek at what we wrote about retirement and redirection, I think it'll summarize this, and also give all of us a pause to think about our own tolerance for risk and how we're sharing that with the family.
Mhm. Great question. Can we just go to Elaine's question? Is it possible to check if a child got a concussion several years ago after an auto accident?
Yeah, once again, this is the good old days syndrome, right? I was a contender, and then I got in a car wreck, and then my life was over. Before that, my life was perfect. I mean, people's recollection of their health before an injury is often through rose-colored glasses. So if a child was in a motor vehicle accident years ago, and if the symptoms developed as one might expect, they had trauma to their head or trauma to their body with enough force to be transmitted to the head, and they had sudden onset or acute onset of neurological symptoms consistent with a concussion, that would be helpful history. If they had a car wreck within 3 years later, they developed these symptoms, the mystery's in the history.
Mhm.
You have to ask different questions because it may not, I mean, this attribution of causation, we're an interest, everybody wants an, everybody says, well, if it, I hurt my back because I picked up this, heavy piece of wood. Over 80% of back pain, we can't determine what the exact initiating cause was. So if I'm hearing your question correctly, I would be very worried to say, if I was in a car wreck, but it took years or months for the symptoms to develop, that the car wreck was the reason. Does that answer your question? Okay.
I think
Cue,
so.
cue, cue collars and helmets. Should I jump into that, Melanie?
Um, can we go to Dave Cracky's question? He's our attorney at Siebert. David's question was, what are the best practices for sideline assessment when a young athlete is suspected of sustaining a concussion during a game?
That's a great question. That's a lawyer question, and a very important one. Okay, thank you for that question. Number one, if there's no medical personnel available, no coach, no parent is to make a diagnosis of a suspected concussion. It's pretty simple. If there's any suspicion, if you're a coach or a parent and there's any suspicion of a concussion, that athlete's out. That's, I think, whenever we have our preseason conversation with parent groups and coaches, that's it. That's when in doubt, sit them out, right? Stand tall, make the call, they're out. If you are a healthcare provider trained in the evaluation and management of concussion, then discipline on the sideline is important. Number one, have an emergency medical action plan. Your duty as a healthcare provider doesn't start on game day. It starts months before. Your EAP should include emergency rescue, duties and responsibilities, who's going to be on the sideline, who's going to work with, how many healthcare providers do you have, game day medical timeout, communication plan. So it all needs to be in place, and that's well written up in a variety of sources. If you're on the sideline, so I guess since I was one of the authors of the sports concussion assessment tool for the sideline, I guess I should disclose that because I like it. We do think that the best way to help aiding in making the diagnosis of suspected concussion is to be disciplined. So the sports concussion assessment tool, version 6, is also freely downloadable. It has an initial section for what to do on the pitch or the field of play, an initial neurological assessment. And that helps you make the decision, do you go to the emergency room or do you go to the sideline? And then we have a stepwise progression of looking at symptoms, at orientation, at memory, concentration, and balance. And it's more sensitive in helping you make a suspected diagnosis by asking all those different domains. Having said that, as we sit here in 2024, the diagnosis of a concussion remains clinical. There is no test. You can go through the SCAT-6 and ace it. But if the athletic trainer who knows the athlete says, doc, she's not like she normally is, they're out.
Mhm.
So have an emergency medical action plan, know your resources, prepare for game day, be disciplined on the sideline, do a thorough examination, and still at the end of all that is a clinical call.
Mhm. Thank you. Um, we have a question in the chat. Do you have feedback on the use of cue collars or the newer helmets that are claiming to help with brain safety in football? And then Stan, after you answer that, if you could go into your history with helping design the ultimate football helmet, please.
Yeah. So let's get it. Thank you for this question. There's no piece of equipment that prevents concussions, right? That's there's just not. Um, the helmet used in football was designed for a very specific purpose. Before the rigid plastic helmet, there were depressed skull fractures in men who played football. That is a very bad injury with a high mortality rate. Since the use of rigid plastic helmets in football, there hasn't been a depressed skull fracture in the NFL in 50 years. And I don't think there's been any that I know of in college or high school if the helmets were being worn. So it did its job. The helmet was never designed to prevent concussion. Um, the claims of cue collars and the newer helmets, what you want to say, and is that it makes sense, I guess, if you can design a piece of equipment that dissipates force better. Okay. So yes, I was involved in helping them build the Vices helmet, working with the brilliant engineers at the University of Washington. I'd like to point out I had no idea what they were talking about 9% of the time. Lots of equations on a chalkboard. And I kept saying things like it can't weigh 30 pounds. I mean, it was an interesting relationship of my practical football knowledge and their extraordinary engineering brilliance. But they designed the helmet with kind of say collapsible um, columns that dissipated force better. And so my counsel to them was that's what you should say. You should never claim that you can stop a concussion. But if you came to me as a doctor and said, what helmet should my son wear? I'd say, look, there's no magic helmet, but all things being equal, if you pick a helmet that's better at dissipating force, which is transmitted to the head, that sounds like a good idea to me. So that's where we are. And the helmets are better at that, and they're rated, and there's a star system, but that should not be equated with making them say that you can prevent concussion. The NFL has data that in their athletes who wear certain helmets in certain positions, the reported concussions are less. That's in very interesting data in the NFL. You have to be very careful to translate that to youth sports. And so I think there's good work being done here. But the other thing, like for example, that you were talking about soccer headgear, you have to be careful not to suggest to a child that they're invincible. And so you give an athlete a helmet or a headpiece, they may be more likely to lead with their head. So we want to be careful about that situation as well.
Mhm.
Helmets they need to fit well, they need to be maintained. And that's where we are, I think, with equipment.
Okay. Thank you, Elaine. Elaine is going back to the accident. Our family was in an accident and I have a TBI. My grandson, whoa, um, has been present to watch my symptoms across the years. He recently told me that he thinks he has one too because he has memory issues. Uh,
Yeah.
so,
Uh, first of all, you give your grandson a hug.
uh,
And tell him that concussions don't sneak up on you. Tell him I can't find my car keys and I forgot what I had for dinner last night. I mean, all kidding aside, I don't know how old your grandson, 10. Um, this is a good opportunity, a wonderful opportunity for you to reassure your grandson that he's fine. And if you're worried about it, to have his pediatrician talk to him, and she or he can also encourage him. His affection for you touches my heart that he feels your symptoms. But 4 years ago, I think he's okay. And I would encourage him not to worry. But, this is a great conversation for him to have with his pediatrician.
mhm, mhm. Yeah. Good.
Thank you, Melissa. Thank you.
Yes. Yeah. I want to go into the AT. We talked before, Dr. Herring, about athletic trainers, and then I want to circle back to return to school because this is very near and dear to our hearts as this return to play. But we have a horrific shortage of athletic trainers in our nation, and it doesn't appear to be getting any better anytime soon. So if you could speak to that, what the problem is and what advice you have for our coaches and ADs and parents and athletes about the shortage and the risks therein.
Well, thank you. And I've spoken about this every chance I get.
Mhm.
First of all, it's amazing to me that we would hire someone to be responsible for the health and welfare of our high school students, for example, and not pay them a living wage.
Mhm.
It's on its face, it seems crazy. Um, Athlete trainers are the field generals. They are. I'm not at the school every day. I'm not the Seahawks or the Mariners every day. You know, even at that level. And so, um, they are such a critical piece of this. Athletic trainers are trained specifically for the things we're talking about, as well as many other pieces as well too. And so I think that listen, when we passed the Lystat law and when I worked with other states, we really wanted to mandate that athletic trainers were hired for every school. And we couldn't get that through because it was just, the states just said they didn't have the budget. If you're lucky enough to have an athletic trainer, get to know her or him, listen to what they say, and insist. I mean, people say, well, listen, when my kids were young and they would go play a sport, I would say, I'd like to know what your emergency action plan is. I'd like to know the training. I mean, I ask questions when I buy a stove or a sports coat. I would ask questions. You know, what's your plan if there's a tragedy? Who's in charge? What is your training? What expertise do you have? And I was always so reassured that when my kids went to a school that had a licensed or certified athletic trainer. So yes, there's a shortage. I think that there needs to be public outcry about this. And I also, listen, schools have booster clubs and they have fundraisers. Raise money, hire an athletic trainer. It's more important to me than doing baseline neuropsychological testing or even some equipment issues. That it's such a missed opportunity, and it's also so unique to the United States. I mean, no, that at Europe and Australia, they don't have athletic trainers. We have this extraordinary resource that's underpaid and underutilized. And people ask me, so they say, hey, when you're on the Seahawks sideline, what do you do when a player's concussed? You know what I do? I say, go find the athletic trainer who knows him.
Mhm.
So you can tell me, I said, do you think he's different? I mean, my dearest, listen, all right, I'll stop talking about this. One of the biggest honors of my professional life was I was made an honorary member of the National Athletic Trainers Association. And I stood up on stage and I said, I'll accept this honor with conditions. And everybody laughed and they said, what are your conditions? I said, that I never have to work as hard as you do. These are hardworking individuals, well trained, great skills, underutilized. We need to sing from the hilltops that there needs to be more athletic trainers in more schools.
Mhm. And the training, certainly at Siebert, we do a lot of trainings and we speak to coaches and ADs. And it's like, if you don't have a trainer, but again, Max's law and Zachary Lystat's law, we need to adhere to this. This is a non-negotiable, right?
Yeah, it will. Uh, if a, in it, We have been fortunate to get laws in all 50 states and the District of Columbia. I know all my state capitals now, and the state bird and the state flower and whatever else it took to advocate. But I think the culture has changed. If a non-medical person puts a young athlete back into play, that is as unacceptable as withholding water from practice now, and we're very proud of that.
Excellent answer to a very sticky question. Thank you. Misty, Misty Griffith has been in the chat here a little bit and she's got amazing questions. She's probation officer, works with many clients, report head injuries, multiple. Sometimes we don't currently screen for this. And this is what we do in Alaska. And we're starting a screener in Oregon. Finding ones who report TBI are in a recurring pattern and not being able to follow through. We don't seem to have a level of care necessary to aid these individuals, and we need more assistance and hands-on help.
Yes, yes, and yes.
Uh-huh.
Um, yeah, head injury and trauma victims, victims of interpersonal violence is a really underserved area.
Mhm.
And I mean, they're victims more than once, right? They're victims of the trauma, and then there's victims of a system who don't recognize it. So you need to send me this Alaska tool like immediately. And yes, there should be screening, but then your challenge begins. These are very challenging patients because they have symptoms that may suggest they've had brain trauma, but they're also raised in this extraordinarily chaotic environment where there's they don't have a safe place. There's food anxiety, right? There's shelter anxiety. There's all these issues which can cause similar symptoms. Oh, I love this, Melissa. Say it out loud. I can't. There we go. Yes.
Piece. Which piece, Stan?
The numbers, Melissa, because I
Oh,
can't.
so currently in Oregon, we're screening in Jackson, the Jackson County facility, and we're about to start screening in Lane County. We also screen in 4 facilities in Alaska right now. And in Oregon, we're finding about 14% of the kids in DJJ, because we're screening all of them, are currently symptomatic, like in the moment, while they're being in the probation system. And then we're coming up with about 40% of them have a history of some type of head injury from a variety of things. And I think you're right, Stan. That's one of the things that's so complex about this population is there's trauma involved, there's dysfunction involved, there's abuse involved. I mean, the list goes on and on.
Right.
So
So
what we found is important is regardless of why they're reporting head injury, if we find these kids, it's like, so what, unless you're going to do something about it, right? And so we have to have some person in place to become the liaison to, if their kid's the school, because that's where they're going to get the services, right? And so if they're incarcerated or if they're in the probation system, they should be eligible for special education, and we should be putting behavior plans in place for them so they can go back to school and be more successful. And so that's the whole point of Siebert's screener. We won't do it unless the facility or the state is willing to work with us to create some kind of system for the kids when we find them.
when we finish this Zoom, I'll be packing up so I can move to Eugene and work with you.
We'd love that.
Promise?
Listen, if I was younger, thank you. This is so important. And that's why I'm such a Siebert fan. I mean, this is thankless work. It's difficult work, but Melissa, first of all, if you can recognize a young person who's actively concussed, has a mild traumatic brain injury, then the chance to treat them properly. And I mean, the one thing we do know is that if you take a young person with a brain injury and you treat it comprehensively and appropriately and get them all the way well, that helps them in their long-term prognosis. I think that is helpful. If you can identify them early. And the other thing too is you can stop this belief system. They say, well, I had a brain injury. And then they give up, right? You can say, look, you provide hope. This is treatable. We can get you better. We'll watch your progress. And then everything else in their life you can address it for what it is versus them saying, well, yeah, I'm done. I had a brain injury. And that's so frustrating to me when there's that just resignation. So I really applaud this work. It's just so helpful and so kind, which is what we need in the world we live in right now. So thank you. Congratulations for the work you're doing, and can't wait to see what you publish.
We're really excited about this study. Yes.
Yeah.
I want to go back to a comment that Elaine made about her grandson having a head injury and that collaborative care intervention model. So in this case, there's a lot of variables. There's a lot of symptomology. Stan, can you speak to that collaborative care and how we can utilize that with a given patient?
Sure, and I have to be careful not. I'm not trying to give medical advice via Zoom, so I don't know those specifics. But let me just, if your son or grandson had a brain injury and he's still complaining of symptoms and they're becoming intrusive, then he needs to be seen to sort this out. And that's at a center, adolescent or pediatric brain injury center, and they will be able to help you understand about the symptoms he's complaining. Maybe he does have persisting symptoms from a brain injury. Maybe, however, he's worried because he sees your symptoms. I mean, you have to sort that out. So I want to be very clear about that. You should seek care. You can start with this pediatrician, but don't let your grandson suffer with beliefs that are intrusive until you know what's going on. Now, having said that, and that's, I think, to Melanie's question. So we believe strongly in the collaborative care model, and particularly for children. And that is, your healthcare team includes the concussion care that some person like me can give. It includes a mental health person who can help sort out the anxiety, depression, need for medication. And it really includes a navigator, right? Someone to coordinate the care. Listen, I need someone to coordinate my own care. I mean, it takes me 4 hours to get an appointment, and I'm a doctor. So, and okay, go see the speech pathologist. Go make this appointment. And they're going, well, wait a minute. I can't get off work to get my grandson to visit. So, someone to coordinate the care in this collaborative model has been proven to us to be so critically important. And if there's not a person, then if you can take on some responsibility to make sure that appointments are met and that messaging is clear, and that means advocating and saying to the doctor who's got his hand on the door as he walks out the room, say, we're not done yet. Can you explain this to me? And I see that's great. You're going to have a webinar with a mental health provider. It's by definition to me, Melissa, a brain injury is a psychological injury. How can it not be? You're talking about the brain, and the brain also is connected to the mind. So let's not dismiss people's suffering, worries, and concerns, and a collaborative care model is helpful for those young patients with symptoms that are persisting and intrusive.
Thank you. Folks, we just have a few minutes, and I want to address the return to learn. Dr. Herring, what advice in your many years, 40 years now, I can't believe it, in medicine, what advice do you have for public schools on how to best address a student returning to learn after a concussion? Loaded question, just do your best.
Sure, yeah. Well, first of all, they're athletes, but there is an important adjective in front of that, right? They're student athletes. Their job is to be a student. That's their job. So that's actually their more important job. So I'm not an educator. So the first thing I had to learn was to listen to people who know how to do this. Teachers know how to teach. Learning specialists know how kids learn. So if you're lucky enough to have them around, you should use them and listen to them. Now, I have to clear kids medically. I mean, I have to do my job. I have an important job here, but a few things. As I said earlier, prolonged cocooning, dark room, bad idea. Okay. So 1 or 2 days of relative cognitive rest. You can watch television if it doesn't make you feel worse. You can walk around the house. You can look at your screens. And then you begin to reintroduce both physical and cognitive activity. In the papers from Amsterdam, we published a graduated return to learn stepwise process. That's a guide, right? And so I think the short answer, Melanie, is early reintroduction, not waiting until the athlete feels completely normal before you let them read or write or go to class. You can be reasonable. But I will say that the majority of athletes who are concussed do not need a formal return to learn or 504, or I mean, they don't. They can get back to the classroom fairly quickly. And yes, there needs to be a period of grace for a week or two, but don't, if they can't go to school at all, if they can't do anything, then get help. Something's wrong. The We are really emphasizing the change now, or the progression now, is this idea of early activation, physically and cognitively. And it's wonderful if your school already has in place a concussion management team, because that will include an educator and a teacher and a school administrator and who's always part of that team is the athletic trainer. Once again, I mean, we're talking about athletic trainers for athletics. Let's talk about athletic trainers and the role they play in helping kids get back to the classroom as well too.
Mhm. Um, One of the things people kind of poke fun at me is I will preach from the hilltops to anyone that'll listen, have a functioning concussion management team in your schools. You can mitigate many problems with this functioning team. Get it in place, and all of your disciplines are reflected on that team. And you have a good communication with your medical community. Our speaker at 1 o'clock volunteers her valuable time here in Lane County, Eugene area to be on our Lane County concussion management team as a psychologist. So we
Yes.
work with her to see what kids have fallen through the cracks versus school versus the medical community. And I can't stress that enough. So, and we have many webinars up on our website about concussion management teams and how to do that. And I'm happy to lead anyone through that process. So thank you for bringing that up,
Yeah.
Dr. Herring.
I mean, listen, wherever you're preaching, I'll come and listen. Um, I'll testify. I'll raise my hand in support of that. Um, the most important part to me, Melanie, is that you planned it, right? I mean, you don't, these are not resources you draw together after a kid is injured.
Right.
This is a culture that you've created. And that you've created a culture that this is how we're going to manage these injuries. And that's helpful because then there's no surprises to anyone. And teachers don't have to figure out on their own what to do about homework assignments, and parents don't have to figure out who to see. That you've provided resources for them, and you've given them structure. If you can do that and have an athletic trainer in your school, you've won a lot of the fight here.
Mhm. Correct, correct. I'm happy to help anyone with that concussion management team establishment. I can't say it enough, and I'll probably stop there. Okay, we have an interesting question. One of our challenges anywhere in the world is being in a rural environment where poverty is prevalent and you don't have access to providers to help with that collaboration between school and medical community. Can you speak to that, Dr. Herring?
Oh, yeah, it is probably a long conversation that occurs over dinner and goes to 2 o'clock in the morning because of the inequities in our healthcare system. But it's so frustrating that we live in this country of extreme privilege and opportunity, yet the disparity in the delivery of healthcare within the same communities often is so frustrating. I don't have an easy answer. I will say that no matter where you live, those people who live there are getting some sort of health care. I mean, there's got to be a primary care doctor. Wherever they go to get their health care, you can see if you can interest that system in maybe a little education around concussion, right? And say, listen, an athletic trainer can give a talk to the local medical group. I've given so many presentations to rural communities, and I grew up in a rural community, and I just love it. So you give them what you have, and you also give them. I mean, they can call Siebert.
Mhm. Right.
I mean, I asked them, what do you do if you have a young athlete with complicated diabetes? Oh, we send them to, OHSU. I said, okay, this is no less important. So if you get stuck, I mean, I work at Harborview. We take any patient, insurance or none, right? And so you have similar situations in Oregon. And yes, it's inconvenient, but we are talking about the brain health of somebody. So educate your community, use the resources you have, educate the parents and the coaches, and say an athlete can be tough, but no athlete has a tough brain. It's a bad idea to push through this. And the kids listen to their coaches and parents, and then help them develop a referral system. that's the best we can do now. I mean, I think there are longer term systematic changes should occur to the healthcare system, but I'll hold that for a different conversation. But in the meantime, I think that's what we do here.
Got a great question from one of our TBI liaisons in the state of Oregon, Joy Hearn. Thank you for putting that question. It's a scenario, actually. So student high school basketball game, hit his head on the floor. Assistant coach did a sideline exam with a light, put ice on his head, hesitated to sit the kid out. Oh my goodness sakes. And here we go. Long story short, reported after the game that he had a sprained ankle. Okay, so again, we didn't recognize remove from play. And I wonder, Joy, was there an AT involved? Because you're kind of in a rural area. I don't know if you can put that in, but Dr. Herring, can you speak to that? That'll be one of our final questions, folks, as we're running out of time here, and we could go all day long on this question.
Yeah, when I get that, I say, well, congratulations, you played roulette with that young man's life and you didn't kill him. Sorry to be so blunt, but that's how young people die. They play symptomatic and they get huge swelling and a big small subdural, and they herniate and they die. That's the Zach Lystet story. That's Max's story. So that coach got away with it. And I don't know the coach and I don't know his or her intent, but it's unacceptable. It needs to be discussed at the highest level in the school district, and that behavior has to stop. That's an opportunity to be an advocate. It's not always pleasant, but it's totally unacceptable. And the coach examining I'm sorry, coach. Okay, explain to me your neurological examination and what you're looking for. Yeah, I mean, the coach is not a doctor, and I'm not a coach. So I'm not gonna coach the basketball team, but that coach is not gonna make medical decisions. And I don't know what the power structure is, but the coach needs to be. This isn't a teachable moment, but it has to be the culture of the school district that this is unacceptable, because it's unacceptable by law in the state of Washington. The attorney who asked the question earlier, it's a good question for him as to what you would recommend they do in terms of remediation for that coach, but you have to do something.
Thank you.
And I sprained ankle presenting, yeah, I have a lot of athletes who tell me they sprained their ankle and they don't know what day it is. I mean, I may have been born at night, but it wasn't last night.
Thank you for your great questions, everyone, today. I feel like we could keep going for about 4 hours.
Yeah.
Please refer to our returntoschool.org website. Also, Matt, if you could, there it is, the link to our survey and certificate. Thank you all for your amazing questions. Please keep them coming. I will circle back with some of you. And again, please reach out to us. We are here for any needs you have. If we don't have the answer, we are going to find it. All right. Okay, Dr. Herring, is there anything you would like to finish up with in conclusion?
Well, first of all, this only increases my admiration for Siebert. And I don't know, and people in Oregon should understand how lucky they are that you're there. So I just want to praise you guys again. I mean, I've admired you forever, and this makes me reinforces why. I'm very grateful that people would listen to this. I hope that our conversation was helpful, and you all are sort of field marshals for this. We all need to be advocates. I'm happy to answer questions too. If there are further questions, we can figure out a way to get the answers back. But thank you for listening. Thank you for giving me the opportunity to start my Friday on an extremely upbeat note. And I can never do enough for you guys. You just, whatever you need, I'm on to help. So thank you.
Thank you so much. All right, everyone. Thank you again for attending on a Friday morning, bright and early. Please fill out that survey that helps guide our webinars, and we welcome your comments and questions after the fact. I will do my best to get back to you. Have a great day, everybody.
Take care.
We appreciate you, Stan. Thank you.
Likewise. Take care. Bye-bye.
Bye-bye.